Hello, Columbia Global Centers Mumbai welcome you to Controlling Cervical Cancer, the third webinar of our series, Screenings That Save, a seminar series on cancer diagnosis and prevention. To begin today's panel discussion, I would now like to invite Dr. Ravina Agarwal, Director, Columbia Global Centers Mumbai. Over to you, Dr. Agarwal.
Thank you, Manisha. Hello, everybody. I welcome you all to today's panel discussion, Controlling Cervical Cancer. As Manisha mentioned, it's the third webinar of our series, Screenings That Save. And we have developed this series in partnership with the Herbert Irving Comprehensive Cancer Center at Columbia University. The Columbia Global Centers in Mumbai is part of 9 global centers of Columbia University that were established with the aim of fostering partnerships with academia, government, civil society, and private sector, with the intent of addressing the global challenges that face the world today, and sharing research, and participating in educational opportunities in order to understand these challenges. So premature death and disability from cancer is a great tragedy that hundreds of thousands of women and their families face every year. Of the various cancers that afflict women, that of the cervix, a part of the reproductive system, as you all know, is a major cause of cancer mortality, and more than a quarter of its global burden is borne by countries in the global south. It is estimated that in India, about 160 million women aged 30 to 59 years are at risk of developing this condition, and around 77,000 new cases are diagnosed annually, with close to 38,000 deaths, representing a case fatality rate of 49%. And every 8 minutes, one woman dies of cervical cancer in India. This becomes even more tragic because the disease is largely preventable and can be cured if diagnosed in the early stages. In today's webinar, our very distinguished speakers, Dr. Kuhn and Dr. Pimpley, will share the status and need for early detection and prevention and preventive measures, and deliberate upon the social stigmas and access issues that act as barriers in implementing cervical cancer screening and HPV vaccines in India and the world. So welcome to our speakers, welcome to the audience, and over to you, Manisha.
Thank you, Dr. Agarwal. Our first speaker for the day is Dr. Sharmila Pimpley. Dr. Sharmila Pimpley is professor and physician in the Department of Preventive Oncology at the Tata Memorial Hospital, Mumbai. She is also currently the head of the WHO India 59 group of the WHO Collaborating Center for Cancer Prevention, Control, Screening and Early Detection. Dr. Pimpley has been a part of numerous research projects and clinical trials ranging from HPV vaccination research, low-cost techniques for cervical cancer screening, artificial intelligence, and assisted technologies in common cancer screening and oral cancer research. She has been a recipient of various national and international awards for her work in the field of cancer research and public health, and has made key contributions in various national screening, control, and capacity building programs. Over to you, Dr. Pimpley.
Thanks, Ravina, and thanks, Manisha, for the kind introduction. I'll be speaking on cervical cancer control as aptly described by Ravina in terms of the global and India implementation perspective, which is so very crucial now since cervical cancer screening has been adopted by the government of India now for the implementation. Well, we face several challenges, not only in terms of selection of the screening tool, but varied challenges, okay, which are varied across our country implementation perspective also. So just to give you a perspective into cervical cancer, which is a very much avoidable non-communicable disease, though the origin is infectious and with gross inequities, not only globally, but within the country also. Now, if you look at the estimates which have been provided, we are fairly in a zone, but much better, I mean, doing a slightly better than the African continent. And our cervical cancer incidence stands at around 18 for the country. Now, to just give you a perspective of where we stand, as it is known by the Globocon statistics that India today contributes nearly 1/4 of the cervical cancer burden, both in terms of incidence as well as mortality. And mortality is another big concern, okay, because despite probably implementing screening program, if you're not able to link it with the appropriate treatment, and the mortality is going to be higher, okay, early detection and screening would have no meaning for our country. So that's one of the important aspects. And I'll take you through as to our experiences in overall implementation for the country, wherein we have implemented rural as well as the district implementation programs and developed models for our own country. Now, if you look at the estimated number of new cases and the projections, the cervical cancer burden is going to increase not as much as the breast cancer burden. Now, we all know that breast becomes #1 cancer for the country now because of the etiological aspects of urbanization, westernization of the lifestyle, and so much of a lifestyle change within our own country people. Whereas the cervical cancer burden is doesn't look to be increasing so much. But I mean, if you look at the sheer numbers for our country in terms of the population, the numbers are pretty high. Now, the interesting aspect here in our country perspective is we are nation, we are multiple nations within a nation, okay? And the share of cervical cancer burden and overall cancers for the female also varies drastically within the country. And that's a interesting phenomenon, which wherein our National Cancer Registry figures are throwing up these numbers, and it in fact help us okay, to look at which are the parts of the country which are doing better and which are the parts which are showing actually slightly increased numbers, where we have to concentrate the efforts also. Now, overall, if you look at for the country, you see that the trends in the 8th standardized incidence rate per 1 lakh women for cervical cancer in the population-based cancer registries for the country have been declining actually across all registries, and majorly if you see the 4 cities of Mumbai, Delhi, Bangalore, Chennai, and Barshi, which is the rural registry. In fact, even the rural registry is showing decline in the cervical cancer incidence. Now, this is much before we introduced the national level cancer screening program. And as it is, we know that we do not have any HPV vaccination program, which is introduced in the national immunization schedule. Now, there are various theories and speculations, okay, as to why the cervical cancer burden is decreasing in our country, despite not having appropriate organized cervical cancer screening or the vaccination program. Probably the reason lies into urbanization, good water supply in the urban areas, probably because of the availability of good water supply and private units for washing and bathing. Okay, this could be contributing to slightly better genital hygiene. And well, I mean, it cannot be supported by any figures in terms of any epidemiological studies which have been conducted. This is just speculation as to why the cervical cancer burden is decreasing. Well, but despite the decrease in the trends, okay, sure, in terms of the number of the population, and as described earlier, every minute there is 1 cervical cancer death in the country, and we need to have this perspective itself lends ourselves and the country to establish good screening as well as linking screening to the treatment also. Now, I mean, very briefly, though cancer, this is an cancer which is arising due to infection called the human papilloma virus, is a group of viruses, and which these are extremely common worldwide, and more than 100 types of HPVs which are seen, but there are a limited number of oncogenic strains, okay, which are responsible for cervical cancer. Now, HPV is a sexually transmitted infection, and most people are infected with HPV shortly, but after a sexual activity. But this is a common sexually transmitted infection, and the peak prevalence is in the early adulthood. It's only the persistent infection or the persistence of the infection with oncogenic varieties or the high risk type, which is the main risk factor for the cancer development. So as said earlier, there are cervical cancer is the fourth most common cancer among women globally, and this is the second most common cancer within our country. The two commonest HPV types, 16, 18, are responsible for the 70% of the cervical cancers and precancerous lesions. And most importantly, HPV 16 has been consistently and most frequently associated. This is the one genotype which is being frequently associated with all HPV related cancer sites also. Besides the 16 and 18, the other varieties, if we combine all 11, 6, 11, 16, 18, 31, 33, 45, 50, 52, and 58, this will contribute to nearly 90% of the cervical cancer burden. So, quickly giving you a grasp of the thing that HPV being sexually transmitted infection, the HPV infection is mostly a transient infection. 80% of the people will have it, it will disappear on its own. There is 80% of the HPV clearance at the earliest possible time, but the clearances differ from person to person, and that's a separate topic in itself in terms of what's the period for the clearance, etc. We will not deal into that aspect. So only 20% are likely to persist, and there are various reasons why a lesion could persist in terms of other reproductive tract infections, cervicitis, inflammation, etc., which helps the virus to stabilize within the mucosa and allows it to integrate. Okay, so these are some of the persistent infection which can turn normal cervical epithelium gradually into low-grade lesions, and some of the low-grade lesions can convert to high-grade lesion. So here at this point of time, I would state that majority of the low-grade lesions also will turn back to normal lesion if the immunity is good. Okay, and if you follow up for a longer time, probably 60% of the low-grade lesions might turn to normal. Only 30 to 40% of the lesion progress towards high-grade lesion, and then further to invasive cancers. So coming to, this is the short etiological component. Coming to screening test, actually, there are a variety of screening tools now which are available, but I would like to briefly describe only three. One is a cytology-based screening test, which everybody is conversant with, conventional pap smear, pap cytology, which we call. There are visual, inspection techniques which have been demonstrated, and there is a good evidence in terms of randomized control trials for visual inspection of the cervix with 5% acetic acid, known as VIA, which has been found to be effective screening tool, and has been demonstrated by our center itself in terms of 31% reduction in cervical cancer incidence if implemented at population level screening. And then we have the molecular testing that is detecting the HPV DNA detection. So now the screening tools per se have their own strengths and limitations. As we know that cytology is highly specific, but the sensitivity of the cytology is relatively low. Now, because of the lower sensitivity, okay, we need to take the test repeatedly on an annual basis because of the low sensitivity. And of course, cytology requires good laboratory and specialty personnel, and there is a lag in terms of the test results. That is, the test results are available after a specific period of time, whereas VIA, that is a visual inspection with 5% acetic acid, has been tested. This is something it's a real time, the results are available immediately. We can see the lesion immediately, and this renders itself to combining the possibility of combining it with some treatment modalities also. Of course, there are a lot of debates about whether we can immediately treat the patients wherein we see the lesion, etc. I think my Dr. Louie Kuhn will be taking up more aspects of the screening tool. The third is the HPV DNA molecular testing, which is considered highly specific and highly sensitive. Now, this is this requires a good laboratory and trained manpower setup, and currently high on the cost compared to the VIA, which is much, much cheaper. It is cheaper than cytology or HPV testing also. It gives immediate results, and you can train any non-medical person also, or paramedical personnel also into administering this particular test, okay, and they can be trained in as less than a one or 2 weeks time, and you can put them into population based screening program. So considering these strengths and limitations, now what is important to understand is screening. I mean, the screening tool is one aspect of the program, and of course a country needs to decide as to which is the most affordable or which is the most cost effective and a screening tool which the country can adopt or choose to implement for that particular country. Now the screening program should be undertaken. Now, screening refers, of course, we know it's a use of simple tests which we can administer across healthier populations to identify which of the individuals are likely to have the disease, but I mean, do not have the disease as yet. I mean, it's used as a screening tool. Now, we have to understand the screening programs should be undertaken only if the chosen screening tools have been demonstrated effectiveness, or there is a good evidence for the same. What are the resources available with us? Which facilities do we have facilities for confirming the diagnosis, because we are choosing a screening test which needs a confirmatory diagnosis in order to take the treatment forward or link it to the treatment. Okay, and so these are the aspects we need to understand primarily for undertaking screening program. Now, considering a developing country, we know that pap smear has been utilized as a, I mean, that has been a gold standard for cervical cancer screening for the last 4 or 5 decades, I would say, until HPV arrived on the scene. And but the developing countries could not take up pap cytology as a population-based screening tool for their own country. Now, there are several reasons, and the time being short, we will not be able to delve into why pap cytology could not be taken up as population-based screening program in developing country setting. Now, herein I want you to understand that the prerequisites for screening in a developing country, I mean, we have figured out that the screening method has to be affordable. Affordable in the sense that, like, I mean, something which could be applied once in a lifetime, because the women are not ready to uh, participate in screening program. Women are not ready. I mean, a test like pap cytology requires multiple call recall in terms of the screening test, undertaking a screening test, provision of this, I mean, the diagnosis of the screening test, undertaking diagnostic confirmation in terms of colposcopy or guided biopsy, and then undertaking the treatment aspects. Okay, so women in developing countries are less likely to come up again and again. Call recall is not working here. Okay, so I mean, there is this aspect of whether the screening test can be linked to the treatment immediately. Okay, so this would allow for on-site diagnosis, something which can provide you on-site diagnosis, and we can and adopt single visit approaches. Okay, because the women are lost for follow-up once once they have come for screening. Many screen positive women are not likely to come back for any diagnostic confirmation within the low middle income country context. Okay, so linking screening to treatment is highly relevant, and we need to explore strategies and approaches, okay, that can help linking screening to treatment, because it's no point screening if the women are not going to come up for diagnostic confirmation and are not going to avail treatment, okay, and herein stands the aspect that what are the prerequisites for a screening in a developing country setting. So screening programs will be effective in reducing cervical cancer burden, or would be effective at the ground level only and only if we have good coverage. There has to be high coverage. There has to be good management of the screen positive. The screen positives have to be effectively linked, okay, to this to the diagnosis and to the treatment. Now herein, in developing country contexts like India, wherein the cancer centers are few, and adoption of the cervical cancer screening programs has been started very, very recently in terms of the implementation aspect. Screening at the primary healthcare level, but primary care level does not have diagnostic facilities. They do not have facilities for histopathology for that matter. There are not enough trained personnel, okay, who can take cervical punch biopsies, okay. There is no provision at the district level also, wherein we can take cervical colposcopy or guided biopsies. There is no histopathology set up, and women traveling so far to the district facilities from primary healthcare centers, okay, it's kind of becoming difficult to link screening to treatment. So these are some of the important aspects. I mean, you have to have high quality of screening test. Need to ensure good quality assured program, even in terms of BIA, which is a cost effective technology. It being subjective, there is a lot of quality assurance which is going to be required, okay, in order to make an objective assessment for the implementation, validation, verification, etc. You need good and adequate infrastructure of trained and dedicated manpower. The logistics, the financial resources have to be in place, and there has to be efficient monitoring and supervision support for the program in order that the program becomes an uh, effective at the ground level, so that the screening happens. There is good coverage of the screening population, which can be subsequently linked to treatment also, which is very, very crucial. So there are two themes currently discussed, okay, in low middle income countries setups, because women are not ready to come up again and again for the screening, for diagnostic confirmation, thereafter to take up the treatment. The call recall is not working. So WHO and international agencies and partnering with low middle income countries are trying to look at newer approaches, wherein, whether we can have single visit approaches, a screening and a diagnostic test could be combined, whether in a single step or in multiple steps, or the two steps taken simultaneously. So for this, the primary screening has to be very, very sensitive, and something like a treatment by cryotherapy, which could be administered immediately. So, these are some of the approaches which we are looking at, so that the women are not lost to follow up if you're screening them. And then you have to look at, if the primary test is very sensitive, it has good sensitivity but less specific, okay, you have to look at triaging this screen positive in some two-step modalities, whatever could be more feasible for that particular country context or the setup. So these are the two themes running currently. And then there are a lot of innovations on strategies for effective sustainable screening modalities. Like, even low middle income countries are looking at reducing the cost of HPV testing, wherein high risk HPV testing could be used as a primary screening modality. We are looking at simplified molecular tests, wherein they can provide us results at a faster rate, immediately for that matter, within an hour or something like that, known as rapid HPV DNA testing. Again, adopt screen and treat and single visit approaches. We can also look at self-collected vaginal samples, because in conventional society, wherein the women are not wanting to come up to the screening testing centers, okay, whether they can do this self-collection at their familiar home environments also. So these are all the innovations and strategy which are being tested and looked at. So now, internationally also, like as I said, screening tool is one particular aspect, but which screening tool to adopt is for that particular country to ascertain as to which is the screening modality which could be best suitable in terms of the cost and effectiveness for their country context. Okay, so we are also looking at resource stratified clinical practice guidelines, okay, wherein we can there are setups which are maximally which are maximal in terms of for the infrastructure, okay, wherein we can have separate recommendations, and there are limited settings, healthcare infrastructure setting, okay, which needs some kind of a different clinical practice guidelines. Okay, so this can be discussed at a later stage, but we can have this resource stratification for various country settings for that matter. So for India, we have looked at resource stratified guidelines, and for cervical cancer screening, we have adopted visual inspection with 5% acetic acid. That's a chosen modality because of the kind of the evidence base that we ourselves have generated, our country have generated, as VIA being an effective and cost-effective screening modality. And this has been adopted by the government of India for population-based screening in the operational guidelines. Now, when I talked about the screening component, okay, it's not about just the screening test. It is not about just the government offering a particular screening test through its public health infrastructure. It is about people accessing the screening test. It is about the affordability. It is about the accessibility. And it is about many more issues in terms of women wanting to participate. If you want high coverage in terms of women participating, what are the current barriers that we are looking at? Because now India has already rolled out its operational guideline and the implementation for VIA as a screening technology for cervical cancer screening. But currently also, what are the kind of barriers that we are facing in terms of higher coverage? Okay, so with our experience of implementing district level model screening program in both the urban and the rural setup, okay, we have witnessed this kind of a barriers in terms of you still need good amount of cancer literacy among women for our country, for cancer control, prevention and screening. Our information, education and communication still has to reach out to wider women population, okay, in order to make them understand as to why this is beneficial. They need to be aware about their body. They need to be aware about the existence of something happening like this to them, and that they have to be made aware that, this is avoidable, this is preventable. They can detect the screening and take up the screening test and detect the precancerous lesions much early. So that's one aspect, okay, which we have to overcome. Then there are public health programmatic barriers also, which we have identified. And of course, last but not the least, India being a country with various cultural practices and variations in the socioeconomic class also across the country, there are a lot of social and cultural barriers which determine the participation of the women in the country. Now, taking you quickly through the barriers. Now, cancer education messaging and reaching this message to the men, we found it equally important that the message reaches to the men also, that their spouses are supposed to be taking up this kind of cervical cancer screening. Now, the adverse, we have also witnessed an adverse impact of factual information sharing for cancer education. Just to give you a clue, that telling women that, look, this cancer is due to HPV and this is a sexually transmitted disease, this backfired on us heavily, in the sense that women started delineating that, uh, HPV was considered something like HIV. This is something sexually transmitted. So this was relegated to commercial sex workers or relating to sex or something like that, which the women started differentiating, and they said, we do not belong to this category. We are not that. And then they they stopped coming and participating in the program. So this backfired us heavily, that the message of HPV being a sexually transmitted disease. So we had to come back to the drawing table again and redesign our awareness strategies, the education strategies as to what we need to inform. Do we need to inform the science behind it, or do we need to inform, what it takes, the benefits of the program? Okay, so we came back to our drawing board and redesigned our IEC strategies again. And then, of course, avoiding rumors and disinformation, okay, once the program is rolled out. Now, the public health programmatic barriers that we witnessed was the attitude of the health personnel is extremely important, because we are examining the private parts of the women, and the attitude of the health personnel reflects a lot in terms of women participating, because that leads to misinformation and rumor mongering. Communication and networking, gaining the confidence of the local communities and stakeholders, I think that was crucial and important for the women, especially from the rural areas, to participate in the program. Navigation within the healthcare system is important. Sometimes the women find it too complex to understand as to where do I go for my testing, whom do I ask, and where is it available. So access and navigation helps, and the frontline workers or the ASHA workers have been helpful in that. And then the lack of confidence in the public healthcare delivery system, that was another major barrier, which has been perennially there, but you need to remove this and help communities participate in the program. And of course, the need for single approaches, because the women do not want to visit the health facilities time and again. And in terms of the social and cultural barriers, well, of course, we can have rims and pages on, describing all the aspects, but I have just enumerated these three components, which we found very, very prominent in terms of the stigma of the cancer outcomes. Okay, yes, coming for screening, and, whether to divulge the report, look, you're positive in front of the other participating women, and things like that. So, there has to be something of, we had to be very uh, guiding ourselves into a strict protocol in terms of the confidentiality, that if we have to tell the women where, how and where we have to tell the women. Can we visit her house to tell the women, or the women has to be called? If she's called, again, she fears that, why I have been selectively called to the health facility, because usually we tend to give the call to, ask her to come for further investigation or diagnostic confirmation. But now even this created a lot of fear and anxiety within the women. And then the women do not want to be singled out, that look, she was called, and the neighborhood knows that she was called again, and that she must be having a problem. Okay, so we are facing all these ground level issues in terms of women participating. So the stigma of cancer in the society, our cancer literacy program has to address this also. Another important aspect which we found was whether it is, cancers are hereditary or not, that is a second aspect. But this also needs to be addressed in the literacy education. The fear of discrimination of the daughters, okay, in the community in terms of their marriage prospects. If the mother is found to be diagnosed with some kind of a cancer, the mother never wants her to be diagnosed with cancer. She would rather be wanting herself to be labeled doctor, they would say, doctor, give some other name to this particular disease, but please do not, inform my family that this is some cancer. You term it as something else and treat me. They are ready to get treated, but without labeling them as cancer. So these are like social cultural issues, and these are not limited to some sections of the women. These are, these are across all sections of the women, and it needs to be addressed at the ground level. And the last but not the least, the need for family counseling. Look, when we are detecting a pre-cancer, she's not suffering from any sign. She's not suffering from any symptoms. It is difficult for her to tell the family for what is she getting treated for. If you're not having the symptom, are you having the concept of a pre-cancer has to be registered, has to be counseled with the husband, with the mother-in-law, okay, in order to get the female treated. So we are at this level in terms of, despite screening program, these are the barriers that we face in terms of diagnostic confirmation and further treatment of the women. So, there are many things to be shared, but because of the limitation of the time, this is what we can address today. So now we have the call for action to eliminate cervical cancer as a public health program. And the life course approach, of course, there are a lot of vaccination trials. There has already good substantial progress which has been made into HPV vaccination program. More than 100 countries have adopted it. We are, as a country, we are yet to decide on the HPV vaccination aspects, and cost becomes a crucial aspect wherein we can introduce this at the primary prevention level. The secondary prevention above the age of women of 30 years, okay, with screen and treat and single visit approaches could be adopted. And of course, linking this to treatment becomes a very crucial and important aspect of the overall effectiveness of the screening program. So the strategy towards elimination of cervical cancer as a public health goal and as a sustainable development goals that the country is pursuing now, we have to adopt measures at the primary level. We have to adopt measures at the secondary level in terms of implementing good screening implementation program and linking them to treatment. So the vision which has been shared by WHO in terms of 90% coverage of the due to vaccination, 70% of the women at least being screened in terms of participation, and out of the 70% screen, if we can link 90% of the women who can get treated, we can expect a good 30% reduction in mortality for cervical cancer. So we are looking at increasing the availability and access to cervical cancer screening programs, both in terms of prevention and early detection. So we can head towards the elimination only if we start acting now, or else the targets are difficult to achieve and we would be having a long way to go. So thank you for your patient hearing, and I'll be able to field the questions at the end of the session. Thank you so much.
Thank you so much, Dr. Pimpley, for such an insightful presentation. Our next speaker for the day is Professor Louie, who is a professor of epidemiology in the Gertrude H. Surgery Center, Columbia University, Irving Medical Center, New York. Her research is focused on how to improve cervical screening programs for women living in low and middle income countries, including women living with HIV. She conducts epidemiologic and clinical research in collaboration with colleagues in South Africa and elsewhere. Her current studies include evaluation of point-of-care HPV tests and investigation of novel digital imaging technologies. Welcome, Professor Kuhn.
Thank you for inviting me. In today's presentation, I'd like to take you through some of the key innovations in current approaches to cervical cancer prevention. And I'd like to reflect on what we can learn from this experience as we have to pivot to face the new threats to cervical cancer prevention that are raised by the pandemic. And like COVID, the burden of morbidity and mortality associated with cervical cancer is not evenly spread around the world. As we saw previously with cervical cancer incidence, with cervical cancer mortality, in these maps that are put together year after year by IROC for the WHO, we see persistent and very stark global disparities in the risk of mortality rates from cervical cancer. Here we see the same data that are grouped by region, showing us age-adjusted incidence rates of cervical cancer in blue and mortality in red per 100,000 women by region. And what we can see in parts of Southern and Eastern Africa, rates are some 10-fold higher than are seen in Western Europe and North America. And in the Southeast Asian area, mortality rates and incidence rates are some 5-fold higher than are seen in Western Europe and North America. And these disparities are essentially explained by lack of access to screening. Since we've had the medical know-how since the 1950s to implement effective secondary prevention through cytology screening, but widespread, well-organized screening has not been universally implemented, and this explains these unacceptable and persisting inequalities across the world. Over the last 15 years, we've also had the medical know-how to implement effective primary prevention through HPV vaccination. After very large clinical trials in girls and young women, 2 highly effective and safe vaccines were approved in 2006 for the Gardasil Merck vaccine, and in 2007 for the Cervarix GlaxoSmithKline vaccine. As we've heard from the previous presentation, HPV is a necessary cause of cervical cancer, and some 14 HPV types are considered oncogenic or causative of cervical cancer. While there's some variability around the world, HPV 16 is definitely the most common, and with 18 accounts for some 50 to 70% of cancers. In 2014, the Gardasil vaccine was expanded to include 5 additional types with a 9-valent HPV vaccine, and this covers about 70 to 90% of cancers. Unfortunately, this vaccine still does not include HPV 35, which is one that's a very common one in sub-Saharan Africa. So there's some variability in the coverage of this in different settings. But the beneficial impact of HPV vaccines is yet to be fully realized for several reasons. First of all, the time horizon on the benefits of HPV vaccine is very long. Because of the natural history of cancer, which results some 20 to 30 years after initial infection with HPV, it really takes at least a generation before we can really see the benefit of HPV vaccine on the incidence of cervical cancer in the population. And the vaccine is prophylactic, which means it prevents primary acquisition of HPV. It does not prevent progression of HPV once you already had it. And that is the rationale for targeting young girls prior to the initiation of sexual activity to have the most impact of this vaccine. There are also major difficulties to ensure access to this HPV vaccine, and coverage of programs has mostly been quite poor for a variety of complex social reasons. So more than 15 years after the approval of this vaccine, only 55% of countries have started national HPV vaccine programs. And you can see the colors that in green here of the countries that have actually started HPV vaccine programs. So while we can marvel at the scientific breakthroughs in terms of developing vaccines against viral infections, we still seem stymied to move these scientific breakthroughs to beneficial interventions for the populations that need them. Shown here are some recent estimates tracking the uptake and coverage of HPV vaccines in the world. And it's looking at 1 dose versus acquiring both doses, and looking at whether it's getting to the target age of under 15. And best case scenario here is we're seeing at best about a 20% coverage. And this is more than 15 years after the introduction of this HPV vaccine. And the incremental improvements that we're seeing here over time can really best be described as modest. So really, we need to do a lot to strengthen these primary prevention of HPV infection. So finally, last year, the global health community has been mobilizing around the concept of eliminating cervical cancer as a public health threat. And last year, this resolution was ratified at the World Health Assembly, calling on the 194 member states of the World Health Organization to achieve the following targets, the so-called 90-70-90 targets. And so the first target is targeting vaccination, aiming to get 90% of girls fully vaccinated against HPV by age 15. And the second 2 targets relate to cervical cancer screening. And they really need to be closely linked to each other, because there's no point achieving screening if you're not also linking to care. And so the first bullet is trying to get 70% of women screened, and focusing on at least twice in a lifetime with a high performance test such as HPV testing, and also aiming to get the screening at the target age, which is around 35 to 45 years of age. And crucial to ensuring the effectiveness of screening is make sure that those women who are identified with cervical disease, including the precursor lesions as well as invasive cancer, are given appropriate follow-up treatment and care in order for this screening to be effective. And we have been talking about how we've been able to do screening for the last 50 years. So what makes us think that suddenly now we're going to be able to do any better than we've done in the last 50 years? And really, I think there are two key innovations that have changed our approaches to cervical cancer screening. And these relate to health systems and relate to the screening test itself. And I'd like to talk first a little bit about our thinking around changes to health systems with the concept of screen and treat. And then I think the crucial development from a screening test point of view has been the shift from using the Pap test or cytology to HPV testing. And there are multiple advantages of using HPV testing. So to talk first about health systems. So in the conventional cervical cancer screening model, we are looking at a multi-step process where a woman starts off being screened with a screening test, and then those who are screened positive are referred to colposcopy. During colposcopy, biopsies are taken that need to be sent to a pathology lab for diagnosis. And then once those results come back, there's referral for treatment to treat the precursor lesions before they can develop. And with cytology, the cycle has to be repeated frequently because of the low sensitivity of cytology. But what also happens with the cycle is that there's attrition all along the way. So there's attrition between once a woman gets a positive screening result, there's attrition in terms of referring her for colposcopy, getting the result back to her so that she even knows she has to go to colposcopy, and as well as there are often very long wait lists to get colposcopy appointments. There's attrition in terms of then collecting the biopsies and getting the results, and there's attrition again in terms of getting treatment. And all of this attrition leads to lack of effectiveness of programs, because the costs of screening are essentially wasted if the screen positive women are not being adequately treated. And they're also stymied by lack of capacity at each of these crucial steps. So the concept of screen and treat is to try and simplify the cycle so that screening can essentially be done in a much shorter time. And you ideally want to start a screen and treat cycle with a highly sensitive test, such as HPV, which is probably the test with the highest sensitivity that we can imagine. We want to replace colposcopy with a very simple assessment for establishing whether a woman is suitable for an excisional or an ablative treatment. Ideally, we would like to go with an ablative treatment such as thermocoagulation or cryotherapy, so that this can be done more safely with a lower level provider. We skip the diagnostic step, and ideally would like to implement the strategy in a 1 or 2 visit approach, so that we can minimize attrition at each of these steps. And our group in South Africa, in Cape Town, was one of the groups that evaluated the concept of the safety and efficacy of screen and treat, comparing VIA-based screen and treat to HPV-based screen and treat, and similar to studies that were done in India doing a very similar approach, we found that, both VIA-based screen and treat and HPV-based screen and treat are better than doing nothing at all. They both are able to reduce the risk of development of cervical cancer precursor lesions that can be treated. But HPV-based screen and treat is far and away the most effective approach, leading to the most reduction in disease. But it has proved particularly difficult to implement HPV-based screen and treat. And one of the big barriers has been the lack of an HPV test that can be easily used at the point of care. So I'd like to just give you a brief example from a study, an illustration from a study that we did in Cape Town, evaluating, looking at the clinical diagnostic accuracy of an HPV test that can be used at the point of care. That's quite simple and easy to use. And we were looking at some of the operational issues in doing point of care, as well as looking at the diagnostic accuracy, particularly in women living with HIV, given the very high prevalence of HIV in the Southern African setting. We screened just over 1,000 women. We collected clinician samples and self-collected samples. All women underwent colposcopy, and then either we had histological samples collected for final diagnosis, and then analysis of the data. And we were using a point of care test that's really quite simple. It's a cartridge-based PCR. You just collect, you put 1 ml of the preserved cyt in the cartridge, and then you just essentially put the cartridge into the machine, and 60 minutes later, it tells you whether there is the presence of one of the 14 high-risk type, and it gives you grouped partial typing, where you can delineate the HPV types shown here in individual channels. And so this is really a point of care test that can be done by somebody with absolutely no laboratory experience. And it is also, each one is individual, so there's no need to batch results. So when thinking about evaluating tests, we've really got to think about balancing sensitivity and specificity, as each of these parameters are really giving us different information in terms of weighing up parameters that we need to know about in screening programs. Sensitivity is going to tell us how effective the program will be, because that's about who you're going to miss, who you're not going to find, because that's telling you about the success of the proportion of disease, that the true disease that you're going to find with your test. And HPV testing is really very, very sensitive, and essentially is getting you almost all of the disease. Specificity is going to tell you about how much overtreatment there is. And so this is either how much overtreatment you're going to give with a screen and treat approach, or how much referral you're going to have in terms of the additional costs incurred through colposcopy and other referrals, as well as the amount of anxiety that you're going to lead to in terms of referring people who don't necessarily need to be referred. And I think in many programs, there's a tendency to want to prioritize sensitivity. And certainly with the way the benchmarks for HPV testing is set, it really prioritizes sensitivity. But our thinking was, let's try and balance the sensitivity and specificity so that things will work better for programs. So we could utilize the additional advantage of the point of care test that we were using is that because it's a PCR, it also prints out for you the cycle threshold value, which is a rough approximation of the viral load. So we could utilize from the same assay, not only the specific HPV types that were present, but could also get an estimate of the quantity of virus that was being shed in the sample by looking at the cycle threshold. And so analyzing these data, we could then compare, looking at whether we could achieve an optimal sensitivity specificity balance by shifting the way in which we interpreted the output from this assay. So if we had used just the conventional way of interpreting this assay of considering any high-risk HPV as being positive, we will maximize sensitivity, and you see here in women living with HIV, the sensitivity is above 90%. In women not living with HIV, the sensitivity is almost 90%, but specificity, while reasonable in women who are not living with HIV, really declines quite substantially in women living with HIV. And so when we wish to do screening in a population where there's a very high HIV prevalence, we really would like to get our specificity improved. So the one way to improve the specificity is to focus on only a subgroup of selected HPV types. And we can definitely see substantial improvements. You can see in women living with HIV, the specificity improves from about 60% to 67% with typing, with really marginal reduction in the sensitivity. So that sensitivity specificity balance is more optimal. And then if we, in addition, change the high viral load and compromise a little on sensitivity, bringing our sensitivity down to 80%, we can achieve quite acceptable and really outstanding specificity with changing the assay, the cutoff to be more stringent so that we only accept high viral loads. So thinking this through, one can really then consider different settings and community preferences and resource availability, which you could use an assay that has the capability to distinguish HPV types and allow for variation in viral quantity, to then pick, in terms of the available resources, what proportion of your population you wish to screen out, as well as, so that one can target scarce resources to the groups at highest risk and achieve maximum effectiveness of a program. So as we return to where we are with regard to attaining these very high, these very aspirational targets for the elimination of cervical cancer, let's reflect a moment on what the impact of COVID is, on these programs. So the one thing is that we've seen a substantial impact of the pandemic on access to childhood vaccines. So it was most marked during the periods of initial lockdowns that happened during the first wave in the spring of last year. And there's been some rebound subsequently. And so this childhood vaccines include HPV. And while there's been some rebound in some of the younger child vaccines over time, HPV vaccine rates have still not rebounded, and this is largely a result of all the disruptions in schooling and the disruptions in summer programs, where there's a lot of catch-up for the preteens with the HPV vaccine. We've also seen an impact of the pandemic on screening, and some of this has been related to fear of attending the health service, as well as the health services being overwhelmed and not being able to accept patients, and preventative services being considered not essential in terms of catch up for patients, and this is going to have longer term impacts. So what can we learn from our efforts to strengthen cervical cancer prevention as we now sit here in our post-pandemic world? Well, I think one of the key things is that we really need to think about how to bridge the gap between scientific breakthroughs, for instance, vaccines, and effective programs to provide access. And as we've seen with the HPV vaccine, more than 15 years, and we're not yet at 20% coverage with this vaccine that is essentially, a highly effective and safe vaccine. And a large part of this is about misinformation. And the anti-vaxxer agenda is very serious and very powerful. And we have to really think seriously about how to counter the misinformation and fear around vaccines. And also, it's also necessary not to go to the other extreme. And we need to understand that vaccines need to be combined with other preventive interventions, that they're not just enough on their own. Thinking through on the screening side of things, we need to think about bridging the gap between scientific breakthroughs, such as diagnostic tests, HPV tests of various kinds, and effective programs to provide access. Because the success of these diagnostic tests depend on the health systems into which they're introduced. And the way in which we use these tests is as important, if not more important, than the actual performance characteristics of these tests themselves, because these health systems are going to determine the impact. We really need to focus on human resources, and in terms of working out how to maximize our human resources. And as we move into an increasingly resource-constrained environment, we really need to think and apply all public health principles to focus on efficiency and effectiveness. And within all of this, we need to think carefully about equity, as equity considerations are really important. And I think I'm going to stop there and acknowledge my colleagues in South Africa, and also would like to thank the National Cancer Institute, who has supported our work. Thank you.
Thank you so much, Professor Kim, for such an interesting presentation. We'll now have the question and answer session that will be moderated by our director, Dr. Ravina Agarwal.
Thank you so much for this very, very informative, set of talks, Dr. Pimpley and Dr. Kohn. There are lots of questions that have come from our audience, and because we're running a bit late, I'll try to summarize them. So just from personal experience, so we've heard a lot about, women and the reluctance to, for various reasons to come for screening and the difficulty in administering that. But this is also, while this is, access to screening is definitely a very stark reality in communities with, less economic resources. But as women, overall, who are not necessarily comfortable or don't, with gynecological screenings, I know for me, it's like, having my pap smear is like going to the dentist. It's, something I dread quite a lot. I think, what are some of the alternatives? I think some ideas of self-collected samples have come up. So some of our audience members, including Nalini Vemuri from ICS Delhi, want to understand the success of the self-collected sample. And they also, another, audience member, Vandana Damarkar, wants to understand about cryo. Is VIA without cryo as impactful as PAP? So, so these are. So I'll pose these questions, and I'll pose a couple more after that.
So I'll address the self-collected because I think self-collected samples are really, one of the benefits of using HPV testing for screening is that we can use both a clinician-collected sample as well as a self-collected vaginal swab. So that's certainly one of the access. And there's, I think, very exciting work that's been done looking at hard-to-reach populations. So people who may be very far from health services, who don't want to have gynecological exams for various reasons. And I think the availability of self-samples really expands access. The other advantage is it can save resources at a health services point of view, because one often doesn't have providers who are trained in doing gynecological exams. So it can then allow you to conserve your resources of healthcare staff to those patients who are going to need to have gynecological exams if they are actually HPV positive and need to be examined. So I think there are many, many advantages. And I think it's an underutilized method that we need to think a lot more about in terms of incorporating into the approach.
This is around the HPV vaccine. Is it what age group is it most effective at? Is it not effective in post 14? So that's one set of questions that's come up, and another question is around this is because we have a lot of stigma associated with HPV. With the issue of sexuality, being an issue. Is this something that you find in other countries as well? And this one was particularly for Dr. Pimpley. How costly is an HPV vaccine, in the Indian setting? Because if cost was cited as a factor.
Cost is definitely the factor for the government to be introducing it into the national immunization program, because if the government of India, if it has to be provided through the immunization program, I mean, it has to be the cost has to come down substantially so that we can provide it to the vast women and girl child population to begin with, actually, because even we are looking at gender neutral HPV vaccination for some countries like Australia has adopted. So then the second aspect is, what are we doing about the cost? Okay, so currently Tata Memorial Hospital is part of a vast collaborative research study for an indigenous vaccine which is made. So now, vaccine is something in the public domain due to COVID, and everybody understands the vaccine manufacturers. So we are looking at an indigenous vaccine which is developed by our country, and then the results of these particular phase 3 trials would be available by 22, and we should be able to roll out actually a good cost-effective vaccine for the country by 23. Well, if it can be taken up in the national immunization program, will still be dictated by the evidence by then in terms of the follow-up of the cohort of already vaccinated girls, including women, in terms of safety. Safety, of course, is demonstrated, efficacy, etc. And yeah, cost certainly is a factor, but among the women who are able to afford it, okay, it is available at a cost of, say, rupees 3,000 per dose. But there's a lot of education and counseling needed to be done before even the vaccine is introduced, or even if the vaccine is supposed to be provided to the mother, to both the mother and daughter, in terms of, the aspects, there has to be good guidelines and protocols which needs to be followed. It's not just about injecting or vaccinating. It is about making them understand also that screening does not disappear. Screening has to go on, move on, and slightly counseling about the benefits of the vaccine, but at the same time some of the safeguards which have to be maintained in terms of not abandoning the screening totally. So that's important.
And it's and 30 to 14 to 30 age group can also take it, right? Or is it
well, ideally the benefit of the vaccine most beneficial is the age group before sexual activity. Okay, so we call it, I mean, HPV vaccine has to be given to HPV naive population, wherein the HPV infection has not set in, and typically HPV infection would be after starting the sexual activity. So like, I mean, ideal age group is the adolescent age group, which has been prescribed below the age of 15 with 2 doses. Above the age of 15, we need to take 3 doses. And of course, bridging vaccination is happening, but we'll have to counsel the women well in terms of the benefits and the need for screening as well.
I have a question on hybrid capture assay. Does that make sense? And the person asking the question, Bhavna Sharma, says, what is your experience of hybrid capture assay for HPV?
Yeah, I can speak to that. So hybrid capture was the first commercially available HPV test, and it came in version 1, and then it came in version 2, and then it morphed into what was aimed to be a point of care test, but unfortunately the logistics of actually using it as point of care is quite hard. You need quite a lot of so it was certainly one of the first tests used. It's a very good test, very well developed, and it's considered one of the benchmarks in terms of when you develop your own HPV test, you have to show that it's at least as good as hybrid capture. So it's taken as one of the benchmark tests. But we are in a fortunate position now that the marketplace is filled with HPV tests. And so there's a lot, you know, obviously they're not all good, but those that have been evaluated, there's quite a lot of choice in terms of available HPV tests that are available right now.
Thank you so much. I'm just aware of the time, and so I'm just going to give a big thank you. You know, it's very eye-opening, and it's you know, to have this discussion, because not only are we I mean, Dr. Kohn, your work in South Africa also, I mean, obviously you've been also looking at inequality. You know, you're working in middle income countries and lower income countries, and the issue of inequality and access in your work, as in Dr. Pimpley's work in India, is very palpable. But for all women, you know, this cervical cancer remains a reality. Our comfort levels with our body, our you know, willingness and our need to you know, undertake preventative care and not neglect that is also very important. So I will thank you, and to all those who are participating, I want to also just leave with this little snippet from, because it's Women's History Month, and you know, Dr. Pimpley was talking about the importance of looking at ethics, you know, in some ways, and appropriate behavior when it came to you know, privacy and the attitude of personnel involved. We all know that well, one of the first women who died of cervical cancer that we know of, whose cells became used for a lot of medical research, was Henrietta Locke, an African-American woman, and she died in the 50s, and her cells were very, very instrumental in the work that was done on various diseases, including cervical cancer. And her family did not give consent for the cells to be used, nor did her family, and that's now being worked at. And that was the subject of a film as well. So we thank Henrietta Locke, and we hope that her example becomes, you know, a big guide for medical practice in India as well, and in other parts of the world, where we are looking at the consent of poor women. And we are also very grateful to this hero, who in her death, you know, was very instrumental in saving so many lives. So I'll leave you with that. And we have our next talk on screenings on oral cancer, which is very, very real in India, next month in April. Thank you so much, Dr. Kohn. Thank you so much, Dr. Pimpley. We hope to stay engaged with you, and see you soon. Bye-bye.
Thank you. Thank you. Bye-bye.